This is by Dr. Anas, I suppose. Ji, Dr. Anas.
Assalamu alaikum, and thank you so much for giving me the opportunity. My topic of discussion is tertiary prevention in symptomatic patients of carotid artery stenosis. So it is actually the prevention of subsequent strokes in patients who already had transient ischemic attacks or had an ischemic stroke prior. So the carotid territory symptoms have already been discussed, so I'll move on. So again, the options are the same as in the secondary prevention: optimal medical therapy, which includes risk factor control, antiplatelets, anti-lipid lowering drugs, treatment of hypertension and diabetes, and intervention through endarterectomy or stenting. So again, these are the level of evidence. Level A of evidence is the highest evidence available, which recommends the treatment, and level C is the lowest evidence available. And these are based on these recommendations. Class 1 is the highest recommendation available, and class 3 is the lowest level of recommendation available in the literature. So moving on, the optimal medical therapy is generally the same as for secondary prevention, which includes healthy diet with low carbs and low fat, smoking cessation, and moderate exercises of 30 to 45 minutes, 3 to 5 days a week, and reducing excessive weight and maintaining BMI less than 25. Long-term secondary preventive therapy should be continued indefinitely. Now, low dose versus high dose aspirin, there was one offshoot of a NESET trial which showed that high dose was more effective than low dose. Later on, a randomized trial was conducted, showed that low dose aspirin was more effective rather than high dose in patients undergoing carotid endarterectomy. Now, platelet therapy, gastric correction during the antiplatelet therapy is generally not recommended, as these omeprazole is thought to affect the absorption and efficacy of clopidogrel primarily. So they are only indicated when there is prior history of gastric bleeding or old age, or the patient is concomitantly taking aspirin, NSAIDs, anticoagulant steroids, or any other drug which affects gastric mucosa, or they are H. pylori positive. It is recommended that pantoprazole should be used because it is said to have less interaction with clopidogrel. Now, the statin therapy, there is one trial, Sparkle trial, but it was not directly related to carotid artery stenosis, but it can, because the cardiovascular disease risk factors are more or less same, so it can be extrapolated. It clearly showed that patients who had 80 milligram atorvastatin had a relative reduction of 30% in non-fatal strokes and 42% in overall cardiovascular events. So it is recommended to use statins to prevent any cardiovascular events during the surgery or in patients of carotid artery stenosis. They are also said to have some anti-inflammatory action on the plaque, and they are said to stabilize the plaque. There was one trial in which 15,000 patients were inducted for non-cardiac surgery, and the one limb had statin therapy continued throughout the time and the other did not. The statin therapy had a 42% reduction in all-cause mortality. And this was also observed in REEF and Vazini studies, but they were for stenting. So it is also recommended not to withhold statins in perioperative time because it increased mortality, which was found out during that study. So recommended that patients who had start statin therapy prior to endarterectomy or stenting, and the statin should not be stopped during perioperative period and should be continued for a long time. It is generally recommended that patients with extracranial stenosis should have blood pressure maintained within normal limits. And caution should be exercised in significantly reducing blood pressure immediately prior to endarterectomy or stenting and in the early postoperative period. But uncontrolled hypertension should be treated primarily, and if you have to delay the case, you must delay it beforehand. In diabetic patients with stenosis, strict glycemic control is recommended, and the blood pressure has to be maintained within the limits, as was discussed by Dr. Saqib. Now, the question of carotid endarterectomy versus best medical therapy. These are the three most talked about trials: the NESET, ECST, and the SVACS trial. You can clearly see the outcomes of in these trials that when the stenosis is more than 50%, there is an absolute risk reduction of 7.8% in patients who had carotid endarterectomy followed by best medical therapy, whereas it increased to 15%, almost double, when the stenosis is more than 70%, and the number needed to treat is also reduced to half when the stenosis. And there is no benefit in less than 50%, and there is no benefit in near occlusion as well. So there were the Nestor trial and the ECHT had a lot of data, and these were analyzed to identify the risk, high-risk patients who had higher chances of post-operative TIAs. These include increasing age, male, recent symptoms, hemispheric TIAs, and increasing comorbidities more than 3. Whereas the imaging predictors include irregular plaque, increased stenosis, contralateral occlusion, and failure to recruit intracranial collaterals. It is recommended that endarterectomy must be done in patients who have more than 70% stenosis, and should be considered in stenosis with in patients with stenosis 50 to 69% in preceding 6 months, provided the documentary risk of stroke and death is less than 6% in that area. So now the most talked about question among the vascular group is carotid endarterectomy versus stenting. Till date, there have been 18 RCTs so far, and 9,500 patients have been studied, which 9 of them included symptomatic patients, 4 had asymptomatic enrollment, and 5 included both. There are 4 major trials: the EVA3S, SPACE, ICSS, and CREST trial. I'll discuss that. So, sorry. The 30-day procedural risks are clearly showing that carotid endarterectomy is far better in reducing any stroke. You can clearly see in EV3S, SPACE trial, and ICSS, whereas CREST is also favoring towards the carotid endarterectomy. But it is worthwhile mentioning here that the most of the strokes were non-disabling, whereas if you can see the disabling and the death rate, it was more or less, although the carotid endarterectomy had less stroke, but it was not that significant. When the data was stratified based on the age, you can clearly see in patients who have age less than 60, the carotid endarterectomy and carotid artery stenting have more or less equal results. But as the age advances, the carotid artery stenting causes 4-fold more risk of post-operative ischemic attacks or death. So again, the long-term outcome was analyzed in a meta-analysis, which showed that stenting to be associated more with peri-procedural strokes. But after 30 days, the results were comparable in carotid endarterectomy and stenting both groups. So it is recommended that most patients who have suffered carotid artery symptoms within preceding 6 months and have age more than 70 years should undergo carotid endarterectomy rather than stenting. Whereas in symptomatic patients who have age less than 70 years, carotid stenting may be considered as an alternative, depending upon the patient's choice and the patient's risk factors, and the peri-procedural risk should be less than 6%. Carotid endarterectomy or stenting is not recommended in patients who have chronic internal occlusion unless associated with recurrent ipsilateral symptoms, or there is a multidisciplinary team who decides that he might benefit from stenting or endarterectomy. Now, the timing of the procedure, as we clearly know from the previous data, that immediately post-operative time, after a TIA, the first 2 weeks have the highest risk of recurrent strokes. So initially, it was thought that endarterectomy should not be done in the first 2 weeks because of the risk of intracranial hemorrhage or because of subsequent complications. But there are 3 audits published apart from the Swedish audit, which showed that there is 11.5% there's 11.5% TIAs during those events. The 2 other major audits showed that there was no risk in there was no increase in TIAs after the procedure. And you can clearly see that carotid endarterectomy, when done within 7 days, had far less TIAs and perioperative procedural death as compared to stenting. that is to be done within the 7 days. So it is recommended when revascularization is considered in appropriate symptomatic patients, carotid endarterectomy should be and must be done within 14 days and stenting should be avoided. Well, I have a question for the audience. A 45-year-old female suffered from a disabling stroke in carotid area 20 days ago and has recovered slightly afterwards, but is unable to carry out routine daily activities on her own. His workup showed stenosis of 70% on ipsilateral side, while the other side is normal. Should the carotid endarterectomy be done in this patient? Well,
so anyone in the audience, or we can do a poll?
Yeah. Very good question, as placed by presenter. 45 years female suffered a disabling stroke in carotid area 20 days ago and has recovered slightly and is unable to carry out his work. Shows stenosis ipsilateral. This is a common patient which we get a consult presenting with delay. So anyone can answer it up. Maybe one of the fellows. We have Ariba, Abdul Basit, and Kamaluddin. Shoaib or Amar, you can actually assess it up. Yes.
So,
Sir,
I would just want to know what would be her functional status at this point in time. It shows that she is unable to carry out her routine daily activities. So, is she completely bedbound, or so? What would be the Rankin score? Rankin score would help us in deciding whether carotid artery endarterectomy should be performed or not.
Yeah.
Rankin score is 3.
Sorry, I can't hear you.
It is 3. Rankin score is 3.
So with a score of 3, I think we should not be offering her surgery, in my opinion.
Yeah.
Well, very rightly pointed out, revascularization should be deferred in patients with significant stenosis because they have a disabling stroke, modified Rankin score is more than 3 or more, whose area of infarction exceeds 1/3 of the ipsilateral middle cerebral artery territory, or who have altered sensorium, or they don't have a better cognitive function, to minimize the postoperative risk of parenchymal hemorrhage. So this is the modified Rankin criteria. The cutoff limit is 2. If the patients have a Rankin criteria of 2 or less, it should be offered to the patient and must be done. But if it is 3 or more, it should not be done. So another question for the audience: 42 years old patient with 70% ipsilateral ICS stenosis, suffering a disabling stroke, but reached stroke center in time and was administered IV TPA, following which he recovered almost completely. Should we proceed with carotid endarterectomy in same admission?
We go for the poll. Everyone can actually say yes or no, please. So we see how many say yes and how many say no. So we get one answer yet. We will add more. Shafullah is with yes. Anyone with a different opinion? So with poll, we get about 3. And there is a hand raised by Dr. Khalil. Ji Khalil, you want to say anything?
Assalamu alaikum, sir. In my opinion, we not offer intervention carotid endarterectomy in this setting because she is having a disabling stroke. We see one recovery of this patient.
Okay.
And immediate urgent stroke within 24 hours recommended in patients with have a recurrent rolling strokes. So she has a single episode of a stroke. So we can proceed within 14 days, but not in this time setting.
Okay, so you want to delay it up, but you will offer the intervention. And then there is a comment by Dr. Fareed, Dr. Fareed, you want to say something?
Thank you, Dr. Zia. No, I think regarding this scenario, yes, we can offer carotid endarterectomy the same admission because the TP is short-acting medication. So maybe giving her 3 to 4 days and then offering carotid endarterectomy would be a good option to slightly increase risk of hemorrhage.
Oh, that is very good suggestion. So we go to presenters.
Early
Yeah,
endarterectomy within
so-
40 days considered after intravenous thrombolysis in some symptomatic patients if they have a rapid neurological recovery, which was in this case. The area of infarction is less than 1/3. A previous occluded middle cerebral artery was recanalized, and there is no evidence of parenchyma hemorrhage or significant edema. With that, yes, heparin antiplatelet therapy should be withheld.
Sir, if I may, I'm sorry to interrupt.
Please.
The continuation of the previous question.
Yeah.
So, sir, what I have read is that previously it was about 14 days, but in the recent most published guidelines of ESVS, which are due to be published in 2023, journal paper is available online. It suggests that level 2A evidence is there that after 6 days of thrombolytic therapy with the stenosis of 50 to 99%, we can consider stenting or endarterectomy depending upon surgeon's preference or intervention's preference. So, but again, it is not a level 1 thing, but level 2A thing. So this it was 14 days, but as per the new guidelines of 2023, they are saying that after 6 days it can be considered, and then completion can be done afterwards in terms of medical therapy.
Thank you, Mark, for updating. Yeah.
Sir, I have written within 14 days. This topic is under debate and under consideration. And thank you for the comment, sir. Yes, within 7 days it can be done, and it improves the outcome as well. The heparin antiplatelet should be withheld for 24 hours after thrombolysis, and antiplatelet should be commenced before endarterectomy, and should have blood pressure control. These patients should have blood pressure control to prevent brain edema and intracranial hemorrhage. With that, I conclude my presentation, and I would love to answer any questions and comments.
So this is very good presentation and very detailed one. I will ask if there are any comments or any questions, they can raise the hand. And this is very important. He has rightly said the indications in symptomatic patients. And then about discussion about the carotid endarterectomy versus stenting. So if you, Anas, you can summarize some of the things which are there. One thing is that you have told, number one is what is the best medical therapy in a symptomatic patient? Can you go through 1 or 2 points for the, actually just for the summary? If you can enumerate.
So thank you so much for giving me the opportunity. It is recommended that if the patient had TIA in the last 6 months, clopidogrel is the first line of therapy. But if the patient had TIA in last 24 to 48 hours, dual antiplatelet therapy should be started immediately, and patient should be worked up for a carotid stenosis. And if the stenosis is less than 50%, or is the internal carotid artery is completely occluded, it should not be offered to the patient. If it is more than 50%, the carotid endarterectomy should be offered and should be done as early as possible.
And the biggest debate you have not, I will say you should the terms carotid intervention. For example, we can offer both endarterectomy and stenting. You have rightly gone through the trials, especially the CREST trial and the other trial which are going. And you have rightly said that although the immediate perioperative morbidity and mortality of the stenting is more, but when we look on the long-term data, there is no much difference. Both are quite effective. So this is one, but and some of the indication more than 50% and less than 99%. This is very good. And then you are rightly conveyed the message that if patient has disabling stroke and has disability, they are not candidates for intervention. This is actually a preventive surgery for the stroke. So this was a nice session. If there is any comments, there is any questions, they are welcome. Sabi, I know you are here.